Today, we're going to be talking about heart disease during pregnancy, which is a serious problem for many women in the United States and Canada. Treating heart disease in pregnant women is not that much different than treating heart disease in the general population, but you may question some of the traditional answers because you'll say, am I allowed to give this medication when they're pregnant? So what we're going to do today is clarify a lot of those questions you can have. It'll be coming right up after this. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, and I am not a stalker. I'm not a stalker. This is my I have many dogs who stalk me around the house t-shirt that I like to wear. If you've watched me for very long at all, you know I love my dogs, and I have 4 dogs. Today, we're talking about heart disease in women. This content is actually found in the Blue Book on page 39. The title of it is Cardiovascular Disease During Pregnancy, I think is the title of it. So there's quite a bit of information. I'm going to cover most of it by going through questions. I'm not going to do like a traditional lecture format. We're going to go through questions to teach you this, but I do still recommend getting the Blue Book. You can order it from Amazon. Mark Klimek publishes it. He receives all the money from the sale of that. I don't get anything, so it's not a conflict of interest for me to advertise it. Okay, let's go ahead and get started. Question number 1. The nurse is consulting with a 37-year-old client who is preparing to start a family. After reviewing the client's health history, the nurse knows the client is at risk for cardiac complications during her pregnancy due to which of the following? History of rheumatic fever, history of asthma, client's age, or body mass index of 24.5. All right, so I'm going to read the question again. They're consulting with a 37-year-old client, so that's the age, 37 years old, preparing to start a family, and which of the following puts her at risk for cardiac complications? So the age doesn't, in and of itself, does not increase their risk for cardiac complications. The body mass index is within normal limits. 24.9 is the high end of normal. So as long as it's within normal limits, that's fine. And asthma doesn't do anything for heart to put them at risk for heart disease. However, rheumatic fever is actually the number 1 risk factor associated with cardiac complications during pregnancy. Question number 2, the nurse caring for a client who is 26 weeks pregnant will have a 30 to 50% increase in cardiac output due to which of the following? Increased heart rate, increased ejection fraction, increased blood volume, or increased vascular resistance. Cardiac output equals stroke volume times heart rate. Stroke volume times heart rate. Stroke volume is the amount of blood that's ejected with each contraction of the heart. Ejection fraction is different from stroke volume in that ejection fraction is the percentage of blood that's ejected with each contraction. So in a normal, healthy heart at rest, the normal ejection fraction is 60%. So about 60% of the blood that's in our left ventricle is ejected with each contraction. Now, the reason it's not 100% is because when we get up and exercise or we have a stress response and our cardiac output has to go up, we have to have some room for that to go up. If we're at rest, we're at 100%. There's nowhere to go when we need more blood. The ejection fraction is the percentage, and the ejection fraction doesn't actually change with pregnancy. The ejection fraction stays around 60%. If you look it up, it'll tell you anywhere between 55 and 70% is our normal at-rest ejection fraction. I always say 60%. So if it's not the ejection fraction that goes up, so I'm going to cross that off. Cardiac output equals heart rate times stroke volume. Well, that's not vascular resistance, so I'm going to cross off vascular resistance. So it's got to either be heart rate or volume. Stroke volume is affected by overall blood volume. And so the answer is actually increased blood volume. The blood volume actually increases significantly during pregnancy, and that's because you've got a baby growing in there and you need more blood and so forth. And so blood volume goes up significantly, which is why pregnancy for women who have a history of heart disease or a history of rheumatic fever, increasing blood volume to that degree can cause the heart to actually fail. And that's why we have to know what their risk factors are for heart disease, because when they're pregnant, that can cause a lot of what we call decompensation. Decompensation means, well, compensation means it's doing what it's supposed to do. Decompensation means it's not doing what it's supposed to do. So decompensation, symptoms of cardiac decompensation, is not doing what it's supposed to do. It's not pumping the blood out like it's supposed to. You're going to see symptoms of fluid volume overload and backup. Question 3, a client who's 30 weeks gestation is admitted to the hospital with signs and symptoms of decompensated heart failure. The nurse knows the expected symptoms include select all that apply. Now, decompensated heart failure is no different in the pregnant person than the any other client with decompensated heart failure. Now, I do have another video on heart failure, and I'll link it somewhere probably at the end of the video so you can know more about that. The nurse knows the expected symptoms are what? So the typical heart failure symptoms, dyspnea with exertion. That's a common symptom of heart failure. So what I'm going to do is I'm going to show you one of the things that I do when I do a SATA question, and I turn it into a series of true false statements. And I also say in general, so that I'm not tempted to overthink. So I'll say in general, dyspnea with exertion is a symptom of decompensated heart failure. True. In general, respiratory crackles in the right upper lobe are a symptom of decompensated heart failure. That's actually false. And you have to pay attention. It says the right upper lobe. It's usually in the bases, and they will do something like that. It's not a trick per se, but there's no reason why just the right upper lobe would have crackles and nowhere else, right? In decompensated heart failure. So that's actually a false statement. In general, jugular venous distension is a symptom of decompensated heart failure. Well, that's true. In general, a murmur over the mitral valve is a symptom of decompensated heart failure. Well, murmurs are a symptom that has to do with blood backup and the valves not closing all the way and so forth. And that can happen in really any of the valves. So in general, heart murmur, no matter where it is a symptom of decompensated heart failure. Or in general, orthopnea is a symptom of decompensated heart failure. Orthopnea is shortness of breath when laying flat, and that is true. In general, bradycardia is a symptom of decompensated heart failure. That's false. Tachycardia is a symptom of decompensated heart failure. In general, a rising blood pressure is a symptom of decompensated heart failure. That's actually false. A dropping blood pressure is a symptom because as cardiac output goes down, which is heart failure, cardiac output goes down, blood pressure goes down. So I don't expect it to go up. In general, fatigue is a symptom of decompensated heart failure. That's true. So you answer this question just like you would for any heart failure question. And it's because in this case, it's because they have an increasing blood volume, and it's particularly if they have a history of rheumatic fever, then this can happen. Question 4, a client who is 38 weeks gestation calls the clinic with the following symptoms. Which of the following would the nurse report to the healthcare provider? So we always report unexpected findings to the healthcare provider, unexpected. So I have to say which of these are expected at 38 weeks. And for me, I'm not a maternity nurse, so I always have to think to myself, what would I expect at this? 38 weeks is considered full term. Most women don't deliver until they're 40 weeks, but 38 weeks is considered full term. So what would I expect? Back pain is expected during the end of the third trimester. That's true. Back pain is expected. It's from pulling on the muscles on the back. That's expected. Urinary frequency is expected at late in the third trimester. That's true. That's because the baby's pushing on the bladder. The onset of regular contractions is expected at 38 weeks. It can be, they're full term. So if they call in and say, hey, I'm having regular contractions, I'm going to say, you're in labor. You know what? I don't have to tell the doctor about that necessarily. I don't have to run and report it to the healthcare provider. I'm a registered nurse. You have to answer these questions like you're the registered nurse. So if you're the registered nurse and they call and say, I'm 38 weeks and I'm having regular contractions. Do you know what you say? You say, how far apart are they? You might want to get ready to go to the hospital. You're in labor, but it's not an emergency. This is normal. This is the normal progression of what you expect. So I'm not concerned about it. I don't have to report it to the healthcare provider. Sudden onset shortness of breath is expected late in the third trimester. That's false. And the reason I don't like it is it says sudden onset. If they just said, hey, I'm short of breath, I'd go, yeah, you're pregnant at 38 weeks. Of course you're short of breath, but sudden onset shortness of breath. Sudden onset, a change in the assessment, and it's not really the assessment. These are subjective findings because they're calling in with these. I'm concerned about this sudden onset, and I don't know what it is, but sudden onset dyspnea is the most common sign of a failing heart in pregnancy. Sudden onset shortness of breath is the most common sign of decompensated heart failure during pregnancy. So that's why I put this question in here. Question 5, a client who's 24 weeks gestation has a history of rheumatic fever. All right, bam, bam, bam. I'm going heart, 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 heart. I'm worried about that. During her regular office visit, the client reports to the nurse that she has been feeling more fatigued than usual. What of the following, which I should have said, which is of the following is the nurse's best response? So which of the following is the nurse's best response? She's 24 weeks. So she's at the end of her second trimester. She's feeling more fatigued than usual. She has a history of rheumatic fever. So I say, well, okay, is that a concern to me? So A, is there someone who could help you with your daily activities so you can rest more? Well, that seems like a good answer. B, we may need to start you on a diuretic. Well, I don't know that. Fatigue alone is not a reason to start somebody on a diuretic. I don't know that we're going to do that. We may need to start you on a medication to strengthen your heart called digoxin. I don't know that either. I don't have enough information to know that. We may need to schedule you for a C-section. Absolutely not. She's 24 weeks gestation. We're not going to schedule her for a C-section. So diuretics and digoxin are used to treat someone who's in decompensated heart failure, but fatigue alone is not enough to say they're in decompensated heart failure. Do you know what the number one treatment for a pregnant woman who has heart disease, the number one treatment is rest, because we need to rest the heart, right? We got to rest the heart. So rest is the number one treatment. So A, out of all these answers, A is the best option. Okay, A is the best option. Now remember, the right answer is the right answer because of the other answers. Compared to all the other answers, this is the best answer. Okay, I'm not saying it's always going to be the right answer, depending on how far along they are, what other symptoms they might have, but based on this specific person who's at 24 weeks and all they're complaining about is increased fatigue, then I'm going to say, hey, can you rest more? Is there someone who can help you around the house so that you can rest more? Question 6, a client who's 34 weeks gestation is admitted to the hospital with a diagnosis of decompensating heart failure. She is complaining of shortness of breath, swelling in her ankles, and fatigue. The nurse auscultates crackles in her lung bases and measures the oxygen saturation at 94% on room air. Which of the following orders would the nurse implement first? Apply oxygen, give digoxin IV push, give furosemide IV push, or insert a Foley catheter. All right, so this is a prioritization question, and I've taught this strategy before in some of my other prioritization lectures, so I'm not going to go deeply into the prioritization strategy, but I'm just going to review it. When you have one patient who has a diagnosis and symptoms in the question, and then it says, which order will you implement first? Implement first. You implement the order that addresses the objective problem, So what do we have? We have shortness of breath, that's subjective, swelling in her ankles. She's reporting it or complaining of it, but we could see it. So fine, that's objective. And fatigue, that's a subjective finding. So the only objective finding we have maybe is swelling in her ankles. The nurse auscultates, here's the objective stuff. The nurse auscultates crackles in her lung bases and measures oxygen saturation at 94% on room air. Her O2 sat is fine. It's within normal limits. We don't need to do anything about it. What's the primary objective finding here? Well, swelling in her ankles and crackles in her lung bases. So which order addresses crackles in her lung bases and swelling in her ankles? The Lasix. That's what we have to do first. We have to do that first. And don't say, but we have to do ABCs. There's no airway breathing objective problem that needs to be addressed immediately. It's the crackles that we need to address. It's the fluid volume overload that we need to address. It's not a respiratory problem. It's a cardiac problem that we need to address. Question 7, a client who's 34 weeks gestation is admitted to the hospital with a diagnosis of decompensating heart failure. Oh, this is actually the same person as the past one. The nurse receives the following orders. Identify which of the following are indicated and which are contraindicated. So this is sort of an example of a next-gen type question. It's more of a standalone, but you can get a question like this. This is typically either the 4th or the 5th question in the case study. And it's the interventions question. So which interventions would you expect? And sometimes they write it in a way that they say, which orders would you expect? Now, I want you to pay attention here because I want to teach you something. It says, which are indicated, which means they're going to help, and they're typically ordered for this problem, and which are contraindicated. Contraindicated means could harm the patient, If all it said was not indicated, I would say, well, it's not going to help, so I wouldn't do it, but it's not going to harm them. Not indicated means it won't help, but it won't harm. Contraindicated means this is actually going to harm the patient. So I'm looking for what generally is ordered and what is contraindicated. So we have the same, let me make sure we got the same person, 34 weeks gestation, admitted to the hospital. Okay, we've got the same person here, 34 weeks gestation, same diagnosis. What orders would I expect? Morphine sulfate, 1 milligram IV push every 4 hours as needed for pain. So here's the question. Would I be allowed to give morphine to a pregnant person? And yes, you can give morphine to a pregnant person. Is it good for the baby? There's side effects for the baby, but it's more important that we keep mom heart healthy than it is to worry about causing drowsiness or sedation to the baby. Okay, the baby's we're far enough along here. Yes, we could cause drowsiness, decrease heart rate with the baby, but we really need to keep mom's heart healthy as long as we can. So morphine sulfate is considered therapeutic and appropriate, indicated in a pregnant woman with heart disease. Warfarin, 2.5 milligrams PO once daily. Absolutely not, y'all. Warfarin, contraindicated in pregnant women. Absolutely 100% not allowed to be given to pregnant women. Furosemide is allowed to be given to pregnant women, and it's indicated here because she's got decompensated heart failure. Heparin. Why would we give heparin? Actually, heparin is considered part of the typical treatment for women with decompensated heart failure who are admitted to the hospital. So heparin is absolutely indicated in pregnant women with heart disease. It's used to prevent thrombophlebitis in the lower extremities due to pooling of the blood. So heparin is appropriate, and sub-Q is an appropriate way to give it. Digoxin is indicated with pregnant women during with heart failure who are pregnant. That's totally fine. 0.9 normal saline, 125 mils an hour. Okay. They're already fluid volume overloaded, y'all. They are already fluid volume overloaded. They have had a 30 to 50% increase in blood volume. And now we're going to give them even more fluids? Absolutely not. 6 grams sodium diet. No, 6 grams sodium is a high sodium diet. We want a low sodium diet. So like a 1 gram sodium diet may be acceptable, something like that. Okay. So those are the correct answers for question 7. Question 8, the nurse is developing a plan of care for a client admitted in active labor who has a history of heart disease. Which of the following interventions should be added to the care plan? Weigh the client twice a day. Sorry for the typo. Auscultate the lung sounds every 30 minutes. Check vital signs every 15 minutes. Maintain NPO, nothing by mouth until after delivery. So weighing the client twice a day is unnecessary. Weighing the client once a day would be perfectly fine, but they're coming in active labor. We don't need to constantly be weighing them, y'all. The weight is going to fluctuate. They're in active labor. So no, absolutely not. Maintain NPO. We don't do that anymore. Absolutely not necessary to be NPO during labor. So would it be better to auscultate lung sounds every 30 minutes or check vital signs every 15? Well, what is the primary problem? If she's going to go into decompensation, if she's going to start to decompensate, what did I say was the most common problem? I told you it's sudden shortness of breath. And why do you think they have sudden shortness of breath? It's because of decreased cardiac output and fluid backing up into the lungs. So what do you think would be the best way to catch that early? It would be to auscultate the lung sounds every 30 minutes. If it said auscultate the lung sounds every 15 minutes, I would still pick it. All right. It doesn't have to be 30 minutes. It could be 15 minutes. It could even be 10 minutes, but you don't want it to be longer than every 30 minutes. Question 9, a female client who's 28 weeks gestation and has a history of heart disease arrives for her routine clinic appointment and has labs drawn. Which of the following lab values is the nurse most concerned about? Sodium 134, potassium 5.1, hemoglobin 9.6, or platelets 155. Okay, which ones am I most concerned about? I'm most concerned about the unexpected findings. So potassium is within normal limits and platelets is within normal limits. Potassium's on the high end of normal and platelets is at the low end of normal, but they're still within normal limits. Don't go, well, they're close to outside. I don't care if they're close to outside. If they're within normal limits, they're fine. So I'm crossing off B and D. So am I more concerned about a sodium of 134 or a hemoglobin of 9.6? Well, they have a history of heart disease. Anemia exacerbates heart disease, y'all. Anemia exacerbates heart disease because you have less oxygen carrying capacity, which makes the heart work harder, which exacerbates the underlying heart disease. So I am way more concerned about a hemoglobin of 9.6. The sodium is 1 point low, 135 is normal, 134 is 1 point low. Plus they have increased fluid volume. So it's not that surprising that sodium is a little low considering how much more fluid volume that they have. Question 10, a prima gravid client with class 2 heart disease who is visiting the clinic at 8 weeks gestation tells the nurse that they have been maintaining a low sodium 1800 calorie diet. Which instruction should the nurse give the client? So I look at this immediately and I go, well, good. They're following a low sodium diet. Is a low calorie diet part of heart disease treatment in general? Is a low calorie diet in general treatment of heart disease? It's not that I'm aware of. A low calorie diet or an 1800 calorie diet is appropriate for diabetics, but I've never heard of it for heart disease. So let's go ahead and look at the answers. Avoid folic acid supplements to prevent megablastic anemia. Absolutely not. Folic acid is necessary, a supplement to be taken during pregnancy. I do know that. I don't know a lot, but I do know that. Severely restrict sodium intake through the pregnancy. Severely restrict. I don't like the word severely, so I'm going to leave it as a maybe, but I don't love it. I don't like the word severely. It's too extreme. C, take iron supplements with milk to enhance absorption. Okay, I take things or I give milk with things to prevent gastric irritation, but I've never given milk to enhance absorption. Never heard of that before. So I don't love it. I don't love it. D, increase caloric intake to 2,200 calories daily to promote fetal growth. Now that makes sense to me. They got it. 1,800 calories can't possibly be enough. I mean, I'm just thinking through this. Like if I'm using my common sense here and I say, I don't know that much, but I do know that you got to have enough calories for this baby to grow. Right? So don't throw your common sense out the window, y'all. Do not do it. And don't go, well, maybe we're supposed to do C. Really? You ever heard of that before? Use your common sense, okay? Don't throw your common sense out the window. Look, I wish you all the best as you're taking it. If you feel like you need some extra help, Clinic Reviews offers the very best NCLEX review in the entire universe, in my opinion. We also do small group tutoring, of which I am a part. So you can buy it. You purchase it as a month-long subscription to our small group tutoring. You get two tutorings by Mark, one by me, and one by Pete, one of our other reviewers. They're also recorded, and you can watch them over and over again on our website if you need to, okay? So good luck on your NCLEX once again. Thanks for watching.